start. We do, yeah. Okay. Hello, everyone. Welcome to the first meeting of the municipal year of JOSC. As it's the first meeting, we need to elect chair and vice chair. Can I have nominations for chair? Okay. A seconder? Thank you. Any other nominations? No? Can we have a vote on Cllr Hayhurst as chair? Agreed. Okay. Thank you. Cllr Hayhurst as chair.
Thank you. And can I take nominations, please, for vice chair? Can I nominate Cllr Deakin? Thank you. And any other nominations? Thank you. Cllr Deakin is elected as vice chair. Welcome, everybody, and to our July North East London Scrutiny Commission. We're joined by a number of new members following the election. So I think for the benefit of everybody in the room, so we all know who we're working with, I suggest we just go through a brief round of introductions ourselves. I needn't do this online to our guests because I will introduce you as we come to you, but this is more to assist us. So I'm Councillor Ben Hayhurst. I'm the Chair of Health in Hackney, and so can I go round this way, please? Cam, can I start with you next? Thank you. Sharon?
Councillor Sharon
Yes, thank you for reminding me. When you're speaking, please, so everyone can hear online. Thanks for reminding me, Sharon.
Thank you. Councillor Susan Masters, Chair of Health Scrutiny, Newham Council.
Councillor Cllr Akram from Waltham Forest, member of the Health Scrutiny, former chairman of the Primary Care Trust for Inner and Outer North East London.
Good evening, everyone. My name is Ahmed Al Kabir. I'm councillor and vice chair of Barts Health Scrutiny, Tower Hamlets.
Good evening. My name is Ahmadul Khan. I'm the chair of the Health and Wellbeing Scrutiny, Tower Council.
Hi, Philip here, supporting the Tower Hamlets Health and Adult Screening Chair.
Thank you very much. I've had apologies from the new Chief Executive of Barts, Shane de Garis, but we're welcomed by Harpreet Verdi. Thank you for joining us, who will be standing in for Shane de Garis. And I've also had apologies from Jackie Smith, who is the chair in common of BHRUT. We've gone through the new members, so I'm not going to reintroduce. Can I also congratulate Henry Black and Diane Jones on your appointments or reappointments within the system. So congratulations on those. Can I just go through very briefly a few matters of housekeeping? This is a hybrid meeting. In fact, all councillors are joining us in the room. We've got members of the NHS joining us online. We are being live streamed. We are being recorded. Members of the press sometimes watch. When you're speaking, please use your microphone. Can I please ask members who and visitors and guests who are online, please keep your cameras on when it's your item. Please keep your microphones muted unless you're speaking, and please don't start conversations in the chat. Declarations of interest. Do I have any declarations? Councillor Masters.
In my day job, I'm a Director of Health Transformation for Hackney CVS, a role that is funded by Hackney and City CCG, which now I'm guessing is now CCG.
And any further declarations of interest? Thank you. If we can please go to the first substantive item we have on the agenda, which is item number 5. This is the implementation of the integrated care system. As we know, it went live on the 1st of July. We're joined by Zina Etheridge, who's the Chief Executive Officer of the ICS, Mary Gabriel, who's the Chair, and Henry Black, who's the Chief Financial Officer. Thank you for your presentation, which appears in the pack around page 15 onwards. I don't know who, Zina, I don't know if you're going to maybe start off. We've got about half an hour for this item. I mean, I've specifically got questions on the, that may be more coming towards, I think I may have sort of fed in beforehand in terms of the money flows. I understand it's a transitional year and then things will hopefully take effect after that. So, some specific questions on those in due course. But Zina, if I hand over to you for maybe sort of a 5 to 7 minute opening or less, and then I'll open it up for questions.
Lovely, thank you very much, Councillor. And I will also bring in Marie and Henry. Can I just check that you can hear me okay?
We can, yeah.
Yeah, brilliant, great, thank you very much. As you said, the ICB, the Integrated Care Board, went live on the 1st of July. We are using, so obviously the Integrated Care Board is both a board and an organisation. So just for clarity, we're using the name NHS North East London for the organisation, sort of that used to be the CCG organisation, so the organisation that supports the board. So just to explain that, if you see references to it. So we had our first meeting on the 1st of July. We started, as we mean to go on, with the first meeting starting with a patient story. We've been really clear that putting residents at the heart of what we do is a really important part of what we want to achieve as an integrated care board and as an integrated care system. One of the early papers that we took to, or one of the first papers that we took to the board was also our people and participation strategy, which I think we'll come to a bit later on. So we did all of that. We did the formal setting up of the committee. On the board itself, we have 2 local authority members. That's Councillor Maureen Warby and Mayor Phil Glanville. On the Integrated Care Board itself, and we are just working through exactly who the membership of the various committees that sit underneath the board are, and we can talk about the committee structure if it's of any interest to you. You've referenced the finances, and I'll come to Henry to say a little bit about that in a moment. Of course, as well as the Integrated Care Board, we've got the Integrated Care Partnership, which we've briefed this committee on before. That's a very broad, wide-ranging committee with a representative of each of the boroughs, or the boroughs and the City of London in North East London. And one of the most important jobs of the Integrated Care Partnership is to set a strategy which the Integrated Care Board has to have due regard to, and we need to produce a first draft of that by later this year. So one of our priorities will be bringing together the partnership through a series of workshops to focus on the 4 priorities that were set by broadly the sort of shadow equivalent of that partnership last year, and those priorities are children and young people, mental health and well-being, long-term conditions, and good quality employment. So those 4 things will make up a core part of that strategy. As I have said at the board when we met on the 1st of July, nobody has set up an integrated care board before. It's the first time for each one of the integrated care systems across the country, all 42 of us. So we do need to treat this year essentially as sort of a learning year. So we'll be keeping our governance under review and amending as we go through to make sure that it's doing what it needs to do. I'll probably stop there and bring Marie in to say anything else about how she wants the board to work or anything else, and then Henry to briefly talk about financial strategy.
We can't hear you then.
Right,
sorry, I did the not putting on the speaker. So in terms of the board, what we really want to focus on is that this is actually a system-wide board. We don't want to duplicate what is already happening within local government, with NHS trusts, which have their own governance arrangements, but to actually build on what they do and have a focus on the 4 aims of an ICS, which are about how we can work together to tackle population health and improve access, experience and outcomes from services, make sure we really do sort of get the most out of the resources we have in terms of value as well. So it really is a kind of an oversight and assurance board, with most of the work taking place at place rather than actually at that system board itself. Thank you.
Thank you. And then Henry.
Thank you, Councillor Hayhurst. So I'll be very brief. As you said in your intro, this 2022-23, this financial year is a transition year, and we have received the kind of guidance from NHS England, a kind of policy position that delegation from the ICB down to either place or collaboratives is not anticipated for this financial year. So what that does, it gives us a bit of an opportunity to kind of take stock and to think through with a bit more of a kind of broader engagement on how we want to use our finances in a different way to, as Marie says, to support those 4 principles. How we ensure that we support prevention, and we move away from commissioning as a pure kind of a role undertaken by a board, a unitary board for commissioning purposes, and how we move towards much more partnership working with providers and other partners around the table, and we move towards a stewardship of resources approach rather than a pure commissioning and contracting approach. But that was all I was going to say at this point.
Thank you very much. I'll throw it open to questions. I'm just aware we've got a lot of new members here, and there's a lot of acronyms being thrown around, and it might be slightly confusing. Just to try and, if I can, summarise it, and I'm sure colleagues from the NHS will correct me. So previously there were several different CCGs for different boroughs who essentially had the pot of money to commission healthcare services for their area. A new piece of legislation has come along, which has essentially required those to amalgamate as what's called the integrated care system level. And so essentially the structures, the governance structure and the financing is now being done at a level of 7 boroughs, North East London, and that's one of 42 throughout the country. And so reference here is to the board, and you can see pictures of everybody on the board on page 20. They will, that is essentially the body that is essentially responsible for making decisions and delivering the strategy, which is set by another group, a partnership, which contains many more people and many more different stakeholders, local authorities, NHS persons as well. So the partnership sets the strategy, as I understand it. The board's job is then to implement that. If I've roughly a very brief explanation to new members. Can I just ask Henry, just on financial flows? So previously, and again, I'm just in my questioning, I'm probably just trying to bring new members along so they can understand the background. Essentially, in the North East London patch, we essentially have 3 systems operating: City and Hackney, Waltham Forest, Tower Hamlets and Newham, and BHRUT, Barking, Havering, Redbridge and Dagenham. And essentially they had their own pot of money to commission their services. Now all the money essentially in generalised has been centralised upwards, and the understanding is that will go on for a year. But then after that year is finished, we were sort of told, what we were told is there was a desire for money to go back down towards a different place-based areas. Is that still the intention, for the money to go back down to those areas for them to commission services that take place in their patch?
So largely speaking, yes. The presence of provider collaboratives means that there are certain aspects of funding which sit with either the mental health trusts or, excuse me, I'm recovering from COVID and I'm still a bit croaky. Excuse me, or the acute provider collaboratives. So there is an intention to enable partnership working by avoiding a situation where every borough has a pot of money for acute, and then effectively the partner around the table, the acute or mental health partner around the table, is then excluded from every conversation. So wherever we possibly can, we're trying to avoid conflicts of interest and ensure that that where the most appropriate place for that to happen is not necessarily at place, but that the place receives the allocation for all of the out-of-hospital stuff, and is also then has full visibility of what we're kind of calling a, I suppose, a notional budget for the totality. So the place will still see the totality of the spend, but to avoid conflicts of interest, there won't necessarily be a direct contracting relationship between a place and a provider, for the reasons that would require the provider to step out of the conversation every 5 minutes. And we want to encourage partnership working rather than the old rules of kind of commissioning, which tended to be much more transactional.
Zina, do you want to come in there?
Yeah, just briefly, and just to say that, and as you said, Councillor, there are lots of new members here. The intention is very much to move away from the old model of a commissioner sort of setting out a series of things that they were essentially buying at the beginning of the year, and the provider, so our provider trusts, so NELFT and ELFT and so on, sort of then providing that. The intention is that all of that system becomes much closer together. So instead of a conversation about what we're going to commission and providers saying what we're going to provide, and then a sort of performance management conversation between them, either at place or any other level, it should be a conversation much more at place about what are the outcomes that we're trying to achieve together using the resources that we've got available.
Thank you. I've got some further questions, but I want to throw it open to members before I ask them. So any members? I saw Councillor Deakin first, and then I'll go.
Thank you, and thanks for the update, Zina, Marie and Henry. Just 2 questions around membership of the ICB. The first one is, I've noticed that originally we were supposed to have the Chair of Barts, Jackie Smith, on the ICB, and it's been replaced by the Group CEO, just whether there's any explanation or reason for that. And then the other one is around, there's a mention of one kind of voluntary community and social enterprise partner being a member of the ICB, just to understand the status of that and what process will follow for selecting that member. Thank you.
Zina, do you want me to go? Oh, yeah. Okay, so in terms of why it's not chairs of the trust, there was a conversation had. They put forward their nominations of who should be on the board, and there's also a conversation with Region about actually how can we best as a board ensure we have the people around the table who we can actually hold to account and who can actually make the decisions at that time. And so we had a conversations, and the trust nominated the 2 executives that you see there. And the second part of your question was about the voluntary sector, was it, Representative? So we're funding a voluntary collaborative across the 8 local authorities, and they are putting forward their nomination. So we're waiting for them. We think we may know who, but we're just waiting for confirmation of that who. But we'll also be seeking a voluntary sector representative as well to sit on the steering group of the Integrated Care Partnership. Thank you.
Councillor Masters.
Thank you. I've got a question about the system of delegation. I mean, one of the real areas of concern over the next year is just what will happen with contracts that are ending. I mean, not so much with the larger contracts where you'd expect there to be a big process, but there's concern if you've got sort of very low level contracts involving small amounts of money, whether those will also have to be dealt with at a North East London level.
Thank you, Councillor. I think Henry is probably best placed to answer that.
Yeah, so there might be a requirement for the contracting organisation to be the North East London ICB, but all of the kind of the delegation of resource and the decision making for, if it's for a small organisation that provides a service at a place level, that would sit with the place, and there'd be no question about that.
And so there's no sort of role at ICB of either vetoing or needing to rubber stamp those sorts of decisions.
Well, rubber stamp possibly, but not veto. I mean, it would, there'd be no, there'd be the expectation that the decision making would all happen at place.
Thank you. Cllr Akram?
Thank you, Chair. Just to get an idea of who does what in the new organisations, I'd like to use an example. Who or which organisation now would be in charge for, say, if a patient wanted to register with a primary care provider, a GP, or wanted to transfer from one GP to another, who would make the decision and do the administration on that now in this new shake-up?
So I'll answer that. So there is no change to the way primary care works or primary care registration. So that patient would do exactly the same as they always have done. I will just use this as a very brief opportunity to talk briefly about a review that's just happened. It's called the full review. It doesn't really matter what it's called, but what it broadly does is emphasise the importance of integrated local care at neighbourhood level. So some people might be familiar with the concept of primary care networks, sometimes called PCNs, which are groups of GPs coming together. Increasingly, what that review and what the direction of travel anyway that London had been on was for those groups of GPs practices to work really closely with community pharmacy, with sometimes with secondary care providers as well, with social prescribers, and in some cases increasingly with local authorities, and thinking about social care at that local neighbourhood level. But that would still not change the way that things like fundamental patient registration worked.
Thank you. Just going back to Henry on the financial flows. I mean, what would be useful, I think, for us on a governance level is I understand what you're saying as to both conflict and how it makes sense for an ICS to be commissioning the providers. So I understand that. But then once that's been taken out of the equation, I suppose that the question that comes to my mind is what is then devolved to place in reality everything else that the CCG's had, and how do we as sort of like an oversight body, how can we reassure ourselves that's the position, or is it slightly less and there might be reasons for that, and what are they? I mean, how when you're going through this process in the next year, how can we see, will we be able to see some sort of flows as to how much, say, CC and Hackney had, excluding the Homerton spend and excluding the East London Foundation spend, and is it roughly the same, or what sort of reassurance can you give us on that?
Okay, so, well, firstly, reassurance, yes, absolutely, we will continue to engage. We've done broad engagement with local councils, and we'll continue to bring those back to this group as well. The principle that I think on slide, I think it's page 15, there are 3 principles that we're setting out. The first is that where those budgets cover inpatient and acute activity or mental health, acute mental health provider activity, that the provider collaboratives are the best places to hold that. But the second principle is that everything else, unless there is a very good reason for it to be done on and a good reason might include that there's an administrative kind of benefit or an economy of scale for certain transactional things around prescribing or things like that. But otherwise, everything else would be automatically devolved to place, and then it will be for place to then make that determination.
And in the interim year, what's happening? Are decisions being made by the 7 CCGs, or are they not sufficiently up and running for that to happen? How's it working right now?
So we are testing that, and we the idea of a shadow year should in theory enable us to enact as if it was working in practice, but simply you just don't have the legal powers fully devolved. So we do have the opportunity to do that and to test some of these things. And obviously each place-based partnership is at a different level of maturity, but we're going through that process now of exploring what those what that test and learn kind of approach might look like.
Zina?
Are still awaiting some guidance from NHS, from NHS England, NHSE, about exactly how all of this this process can work as well. So just to say that there is a little bit of central guidance that we're expecting on this as well, and which we don't yet have.
Thank you. Councillor Adams.
Yes. Sorry, thank you, Chair. I was just looking at the structure. We have 8 local authorities and 2 local authority partners member on the ICB. What process is used to select these 2 local authority partners members on the ICB?
I'll come in there if that's okay. So it was rather similar to the trust. So we asked local authorities to nominate their 2 members on the Integrated Care Board, just as we did with the NHS Trust and as we did with primary care. So there was a process of conversation which we weren't party to within local government. We wanted to make sure we had a good spread from the inner and outer bits of North East London, and we were advised of who the 2 members were. Thank you.
And Mary, just building on that, we see at page 20 on the sort of slide deck lots of portraits of who's on the ICB. Does a similar slide exist for the partnership yet, or is that still in the process of being worked out?
So we probably won't have one slide for the partnership because I think they'll end up being about 40 people. But we will do a slide of the actual executive steering committee, sort of the group that's going to make sure things happen in between, which again will be representative of the different boroughs. So a couple of chairs. We know that it's going to be Sultan from North East London Foundation Trust, and Jackie from Barts BHRUT is going to be the chairs, but we're doing the same thing. Voluntary sector, local authorities will be on that, and we'll have a nice little slide where you see the pictures for that. I'm not sure we've got the photos yet of Mayor Gamfield and Councillor Warby, but we didn't quite get the confirmation at that time to send in the paper.
Sorry, has the membership of the partnership been finalised yet? Sorry, or is it has been?
Yeah.
And on this question of the workability of that, because as you said, I think you alluded to there, maybe 30 or 40 people. I mean, it's been a long ongoing concern, I think, of ours, as it just being essentially too unwieldy. You've got to bring everybody in. So that they have a say and sense of governance. But in reality, how on earth is that going to work to make to be a meaningful body?
So what we're focusing on are the 4 areas, flagship priorities that the partnership have already said in its shadow form they want to focus on. Zina talked about children, young people, mental health, good work, and long-term conditions with a focus on prevention. So through that partnership, what we're expecting to do is have workshops on each of those to actually provide more detail about what we're going to really focus on, and then from that develop a strategy, and then we'll be bringing after those four partnership workshops in the next years, we'll be going to that wider partnership to say this is the progress we're making for them to be able to ask questions, but also to inform the strategy going forward about what next do we know we need to do. But there'll be this smaller steering committee that's represented from the partnership that will make things happen in between and check on strategy and take it through their constituent bodies in the same way that we did the nominations from the ICB.
That makes sense. So how the ICB meets monthly, and then you've explained how there might be separate subgroups based around the 4 themes of the partnership. But what does the partnership also then meet monthly as well? How do the 2 then interrelate?
So we're thinking at the moment, but of course it's all new. So if it may be different when we get it up and running, but we're thinking the big wide partnership will meet 4 times a year, and that the smaller committee will meet bi-monthly, because we recognise all the work that has to happen in between and the commitments of partner members.
Thank you. I'm looking around for further questions. One matter, obviously, this is quite a Hackney-centric question that I think historically concerned us is, of course, you haven't got the chief exec of the Homerton on the ICB. You do have the chief exec of Barts BHRUT. I mean, I think when I asked Jackie Smith that question sort of 6 or 9 months ago, it was essentially, she was saying she had conversations with the chair of the Homerton and was very much attuned and was going to represent both. I mean, there is clearly has to be possibly I guess you'll give me the same answer now in the sense of having the CEO there, but at some extent, is there any risk of conflict there in terms of just having one secondary care lead but not the other?
I think the way in which we're working with the acute sector, as an example, is actually through the provider collaborative. So there's an acute provider collaborative board, and so what the chief exec of Barts BHRUT will be being put forward is not his view as Barts BHRUT, it's his view as an acute person, and that's actually within our governance and the requirement actually within the Health Act that they have to act on behalf of all the people of North East London, and they're not there to represent their individual organisation. So but there are continuous meetings with the Homerton, but they will continue. Zina might want to come in terms of place leadership as well, because Zina's coming in. So in terms of the leadership at City and Hackney, for example, that will be by the Homerton, but I'll hand over to Zina.
Lovely, thank you very much, Marie. Marie referred to places. We've also been through a process of identifying a series of key leaders at place for that place. So you might be aware of the integration white paper, which set out the need to have a single leader at place who could look across health and care at that level. So we've been through a process of asking each each place, the partnership in each place, who they would like to nominate as their leader for that place. In City and Hackney, that nomination is Louise, who is the new chief executive of the Homerton, obviously, when she takes up that post. So she will have a very strong role at place. The other thing is probably worth referencing is the executive. So somewhere in the governance chart you've got in your papers, you'll see that there's reference to an executive committee. So that is the executives of the key parts of the system, and that includes the Homerton. And as Marie said, the Acute Provider Collaborative provides quite an important part of the governance structures of the Acute Provider Collaborative, and that has a link up to the boards of each of the trusts, including the Homerton.
Thank you. And I suppose one other observation might be that the success, I suppose, of the new ICS model might well really depend upon right down at the base level of the PCNs. What support are you giving them so they can set the ground running in the best way? I mean, the experience we had, I'm just going back to One Health in Hackney meeting a few months ago, is that there's issues to do with space. They're being asked to take on extra resources. They don't have the building. They don't have the capacity. They're revolving chair around themselves, say, every month, which that to me, that was screaming lack of continuity, lack of leadership, the institutional memory changing. I mean, what support what program are you giving at that level to really make that a success?
Yeah, thank you very much, Councillor. No, I mean, I guess one of the bits of support is that there's quite a lot of learning from across North East London that we can really successfully take into other parts of North East London, including the work that's happened in City and Hackney on the development of locality and neighbourhood teams, which I think is really helpful. We are planning a system-wide workshop later in the year to really look at how do we make integrated locality working a success for everybody, to share some of that best practice, understand what the barriers are, and understand what the opportunities are. The kind of third piece is that we've talked a little bit about the acute provider collaborative. We are relatively unusual as a system in setting up a primary care collaborative as well, because we think it's really important that there is a vehicle through which that development of primary care, and that is all 4 strands of primary care. So that's general practice as well as community pharmacy, optometry, and dentist and community dentistry. That there is a clear support mechanism for them, including for development of PCNs and locality working. And then finally, the NHS North East London, so the organisation that I referred to that has taken in the CCG's staff, still retains a significant number of people who support primary care and will support PCNs in their development.
Thank you. Any further questions from members? Councillor Masters?
It's just a quick one about culture, and you kind of sort of started addressing it there in terms of your workshops, but there've been a number of articles recently about the experience of sort of integrated care across Britain and clashes of sort of culture. I mean, in our integrated care system, we're bringing together local authorities, the NHS, community and voluntary sector, residents. How are you going to ensure that culturally everybody sort of comes together?
So, okay. So I'll start. So we've already done quite a lot of work as a wider partnership about the signature behaviours that will determine how we're going to work together. So we've got sort of what we call our design principles, or our four cornerstones, which actually talks about how we will, everything we do together has to have the focus on working with the people of North East London to improve health, wellbeing and equity. And our focus should be on this joint work to improve quality and outcomes, to secure greater equity, to create value and to deepen collaboration. So there's definitely a piece of work on that. There's also the legal requirement for people now, local government and within the NHS, to there's a duty to collaborate. So there's an expectation, and regulators will judge us on our ability to work well as systems. But you know, actually, there's been a real commitment from all partners across, and a welcoming of the potential of how we can do more together than we can individually to really improve care and outcomes for our populations. Zina, sorry.
No, Marie, you put it much better than I would have done. I mean, and really, every part of the system has a role to play in making sure that that culture of collaboration really takes effect. And certainly, it's something that we will be working with our places to understand what sort of development and support is needed at place to develop the right sort of culture there as well.
Thank you. Unless we're nearly at time on this item, unless there's any further looking out questions on this, I will bring this item to a close. Thank you. I mean, it may well be that we've sort of, as this has evolved, we've sort of had regular updates on this. It may just be, I'm thinking off the top of my head, it maybe we can sort of lessen the frequency of those now, seeing it sort of slightly bedding in a bit more. But I mean, we can maybe think about that when setting the agenda for the next meeting. Can I now move on then to the next substantive item, which is item number 6. This is the update, the East London Health and Care Partnership update section. There's a number of items. So if everyone turns to page 40 on the agenda pack, there's a whole host of areas, and also what needs to be added there is an update on whips. In terms of colleagues from the NHS who are presenting, as I welcomed at the start, we've got Hayhurst Verdi, who's the Group Financial Officer for Barts and BHRUT, Diane Jones, who's the Chief Nursing Officer, and Anne Hepworth, who's the Director of Strategy. And also when we ask specific questions, which I think we will do on OPROs, we're also welcomed, we're also joined by Alison Goodlad and William Cunningham Davis. And also in relation to the Community Diagnostics Hub by Nicholas Wright. I don't know whether you've given any thought to how you want to present this. I don't want to, maybe a quick run through the different areas and then we open up for questions. Just to flag, we've obviously got concerns and questions on OPROs. I think we're particularly interested about the continuing healthcare policy and any interaction with adult social care, and an update on WIPs was some of the sort of the key things we were sort of thinking about beforehand. But over to you, and then we'll fire with questions.
Thank you, Councillor. So what I'll do is I will try and compare everybody in to give, as you say, a pretty brief update, because the committee has the pack in front of it, and then we can use some more of the time on questions. So I'm going to start with Hardev and then move through Diane, Alison and William, Nicholas and Anne, and then I've got something to just add at the very end. So if I start with Hardev.
Can I just ask colleagues, because we've got the pack and we have read them, I'm just conscious that I don't want this to sort of become half an hour's worth of presentations. So maybe just keep it for 1 or 2 minutes with the key points, and then we can fire into questions. Thank you.
Brilliant, suits us, I think.
Thank you very much. So, I'm Hardev, the Group Chief Finance Officer for Barts Health. And just to start off by giving an update regarding appointments as well for Barts Health and BHRUT, as you mentioned at the start, Councillor. The appointment of Shane DeGaris as the Group Chief Executive is now the accountable officer for both Barts and BHRUT. That mirrors the arrangement we have with Jackie Smith as chair in common across both trusts. And each trust will continue to have their sovereign decision making through their trust board, and we're working through the priorities and services and the importance of the services for our patients, and to deliver a financially stable set of organisations. Shane DeGaris starts his formal role on 1st of August, with Alwyn retiring this week. Matthew Traynor, he's been designated as Group Deputy Chief Executive Officer with a role on the Barts Health Board, and we've substantially recruited to the 3 hospital chief exec vacancies, with Ralph Colbeck, who's with us today at Whips Cross, Neil Ashman, who's at Royal London, and Simon Ashton, who's the chief executive now of Newham Hospital. So those are the latest regarding our appointment process. As you said, Councillor, I'm not going to go into detail regarding the presentations. We continue to work on the continuation of delivering lots of care for those patients who've been waiting more than 12 months, and in some cases 104 weeks. That's progressing well, together with the work to reduce waiting times for those over 78 weeks as well. And as you will have read in many of the articles nationally, lots of pressure on our workforce. And whilst we still have elements of the pandemic, we are ploughing through as much activity, trying to deliver it in the right place, in the right setting, and as efficiently as possible. So the rest of the information pack goes in more detail regarding the acute setting, with areas around developments on things around the monkeypox scenario and other aspects, but I won't dwell on those, therefore information. So with that, I'm happy to hand over.
Shall I just take it? Thank you very much, Hardev. And I think, as Hardev says, we've got Ralph Kilbeck here to answer questions about the Whips Cross redevelopment, if you'd like to get to that at the end of this update, Councillor. So Diane, I think, is going to come in next and do a very brief update about vaccination and continuing healthcare.
Thank you. So the brief update on vaccination is that we've continued throughout the summer to offer the vaccination programme. We have seen a reduction over the summer period in people wishing to uptake the offer on their vaccination, but there are still people coming through each day. We've just submitted our plans for the autumn booster, where we will be vaccinating the cohorts, which are cohorts 1 to 9, but most importantly, the areas that we want to concentrate on are the most vulnerable, our young people, and also those who are seldom heard, who others will consider as underserved. So our vaccination programme most definitely takes into account addressing those inequalities, the areas where we know people are most vulnerable across our populations, and making sure that we have an outreach service for that, as well as the core offer within some of our local sites. We are trying to combine so that make every contact count. So where people are coming forward for vaccinations, we also want to be able to offer health advice as well at the same time. And so we're putting plans in place to try and utilise the space more efficiently with other services that can go alongside those vaccination offer that we'll be undertaking during the autumn period. In relation to continuing healthcare, this is care that is in addition to the universal offer of care where people may have complex needs. And what we're looking at is we have a variety of policies that existed within the individual clinical care groups before clinical commissioning groups, before we became one across North East London. So what we're looking at are all of the policies and trying to align them so we have a more streamlined approach that not only does it enable us to offer a better service to our residents, but also for the staff that are actually involved in undertaking those continuing healthcare assessments and reviews, that we all have a consistent approach in the way that we do that. And we've looked at these 4 policies first because when we spoke with teams, we spoke with our clinical teams who undertake these assessments, these were the areas that we felt were more complex, that we felt we needed to try and align these first off. But there are further ones that we'll need to do further down the line. But these were the key ones that people spoke about and said, actually, if we can get these right and get some systematic approach to this, then that would be really helpful. And the way that we've done this is we've been talking with our clinical colleagues who undertake the assessments. We have a small working group that has local authority colleagues and care colleagues and health colleagues that are on those working groups. And what they've done is they've developed these draft policies by looking at what the existing policies say. We've looked at the national framework and we've considered what is best practice to draft what are the policies that we're sharing and we will start to engage on in a couple of weeks.
Thanks very much, Diane. There's a lot of information about about cancer and cancer performance in the pack, which I think we're not proposing to talk to, but very happy to answer questions too. I'm going to ask Alison and William now to come in and do a quick range across primary care.
Okay, I'll kick off. Yeah, so we've provided some information on the Primary Care Winter Access Fund. So we were, NHS England gave us an extra 9 million this winter to help to address the challenges of access in primary care. And this additional funding was really helpful in terms of giving us additional capacity and more workforce to help us through, particularly through the challenging Omicron wave. And, it really did help practices not to close and to keep them going. And the other part of the funding was on sort of more longer term sustainable change around access. So we invested in things like training, software platforms so we can understand patterns of demand across practices, work with Health Watch to sort of engage with patients around communication and engagement around access, and some intensive work with practices experiencing particular challenges around access to help them in terms of quality improvement techniques. The other area that we've provided some information on is the enhanced access to primary care. So this is a change in the way that that practices and primary care networks provide primary care outside of their core hours. And so as from October, they will be sort of primary care networks will be coming together to offer all their patients primary care services on Saturdays between 9 to 5 and in the evenings from 6:30 to 8. And PCNs are working on how they're going to put that together at the moment. But one of the really important things they need to be doing is engaging with patients and providing services in a way that best meets their needs. And so we've been supporting them around a survey, a big patient engagement survey, where that information has been shared with practices and PCNs. And many of you may have received a text inviting you to participate in that survey. I'm pleased to say we had a huge response. Nearly 40,000 responses, and so that all that information has been collated, and then so practices and networks of practices are using that information to help to inform their plans going forward. And we're also, one thing that we really don't want to do is to lose some of the capacity we have on bank holidays and Sundays at the moment. So we're going to continue with a level of urgent care access that we have on Saturdays and bank holidays, and there will be a change in the way that that enhanced primary care services are offered on Saturdays and in the evenings. But we want to try to sort of to really deliver this in a way that meets patient needs. And in the longer term, there will be further work from next year around how urgent care can be provided in a much more integrated way. And then finally, I know there were concerns around Opera's health and 18 medics. So we have 18 medics practices in now that are part of that Opera's health group. And following the recent report, the Panorama report, we've been following that up by having meetings with 18 medics and undertaking some key lines of inquiry, following up points from that programme to be able to give us assurance around their clinical governance and their operating models. So these are being reviewed by clinicians, and they will highlight if there are further areas that we need to investigate further. So the intention is that we want to kind of pull together a sort of a governance and assurance framework to use with all practices around that, particularly the use of sort of new workforce roles like physicians associates, and ensuring that there are sufficient and adequate and appropriate supervision arrangements in place. But certainly from our initial review, that they have provided evidence to that they don't have a backlog of patient documentation, and they have provided detailed evidence around training, induction, and supervision processes for their physicians associates. So we've been reviewing that, scrutinising that in detail, and looking to see if we need to undertake further investigation. And also the CQC in parallel have been visiting those practices as well.
Thank you, Alison. And then if we could just have a minute on community diagnostic centres from Nicholas or Anne.
Hello, everyone. So this is an update on the community diagnostic centres. We've been here before to talk about the broad concept, and the update, effectively, for those who are unaware of them, they are sent. It's a nationally mandated and coordinated programme to improve and increase access to diagnostic tests like MRIs and X-rays all around the country. We are going to have 2 of them, we hope, in the first wave in Mile End and Barking. They have been submitted as loose proposals to NHS England, and we have received authorisation to spend up to £15 million of additional capital into the system for Mile End. We expect to receive the same for Barking in a week or 2. We have also just begun a public consultation period where we are going to ask the public's views on what we should be doing in those centres, how they should run, if they're in the right place, and all those elements. So we plan to then continue to move on beyond this first phase to see how much extra capital we have left, and then use that in building a 3rd, possibly a 4th site as well, to effectively spread the provision for community diagnostic centres around all of North East London.
Thank you very much, Nicholas. And then last bit is just from me, is to set out, and it's in your pack. So the 3 acute trusts in North East London have got a range of changes and improvements to acute services. Some of these have been in development for a long time. Some of them are things that happened during the pandemic, and there's quite a lot around. In terms of clinical strategies, there's these various proposals and how they relate to clinical strategies. The trusts are in different positions on all of them, and as the acute trusts are coming together in the Acute Provider Collaborative, the Acute Providers Collaborative are planning to do further work on an aligned system-wide strategy, which looks at which looks at how all of these things come together. They are meeting in July in order to kind of formally commission a review across all of those pieces, and we expect that there will be the opportunity for a first overview of those proposals that all three trusts can support, including plans for engagement and consultation that we'll be able to talk to the committee about in late autumn. And then finally, you've just got a slide on page 55 of your pack, I think, which summarises some targeted investment fund bids we put in, which we hope will result in some additional capacity in various parts of our system. So I will stop there, Chair, and leave you to any questions.
Thank you very much. Members, any questions? Councillor Masters?
Thank you very much. I'm one of those who was sort of highly disturbed by what was seen within the Operos documentary. I'm just wondering, in terms of the assurance framework, what kind of timelines are involved, and how far it's possible to scrutinise a body like a GP practice, and also just whether it will contain controls on the balance between these new roles like physicians associates and GPs, because that was one of the practices sort of criticised within the documentary. Just whether that will be part of the new assurance framework.
Thank you very much, Councillor. I think I'm going to ask William if he wants to come in and answer that, assuming he's with us. Sorry, I can't see everybody on my screen.
Yeah, no, thanks, Zina. Yes, so within the, as Alison said, the key lines of inquiry, there are some criteria within it that certainly the team have been in to see and to be able to visualize and see the kind of performance and scrutiny, or the kind of one of the criticisms was lack of supervision. They were able to share with us the supervision program that they undertook with their teams and with their members of staff. And like we said, obviously the R's roles aren't just unique to a pros. They are part of the NHS England kind of workforce. And as Alice was saying, we'll be using the key lines of inquiry on all of our practices in North East London, not just a pros, so that we are able to assure ourselves that they are having suitable training, suitable guidance and governance that sits behind it. So again, is timescales. We're looking. Also, the teams have been in. I know that the CQC have also been in to visit the practices, because obviously, as Alison was saying, there's more than one contract in North East London. Obviously, a pros program wasn't just around North East London; it was of the whole group. Obviously, the contracts are held by 80 medics, not a pros. But ultimately, we've obviously gone to the practices that we have in North East London and assured ourselves of what was exposed within the BBC documentary. We also asked the BBC for further information and evidence to review. And like I said, the key lines of inquiry have been very pointed to what we felt from the panorama programme. And so far, from what we've seen, we were able to assure ourselves. And as Alison was saying, we have taken additional clinical kind of aspect of that oversight for our clinical members to really drill down on the clinical oversight.
William, can I? Oh, sorry, you go first.
Thank you. I was just hoping to get a supplementary there. So you haven't given me an idea of timelines and answers to my question. And also, I'm just wondering if you can be clearer as to how you can be assured that they are actually delivering the services the public would expect to see, because that I feel was the problem, that there would have been oversight practices in place, I would hope, previously, but clearly they weren't sufficient to stop things going on behind the scenes. And I'm just wondering how you can assure yourself that what the information being provided by Operos is actually accurate and actually reflects these services that the public are experiencing.
So yeah, so like I said, we've been into the practices, and Alison, I mean, certainly you can chip in certainly around timescales. They're imminent. All we need is that clinical oversight. But we've been into the practices, and the evidence that they've supplied us, we've then been able to validate against what we're seeing within those practices. So again, Alison, if you can just answer the question about the timescales.
Yeah, because we asked for we had a very short sort of timescale for them to respond to us with the information and the evidence. And I just heard back from the clinical workforce lead who's been reviewing their submission today. So so there's just a few sort of follow-ups that we want to pick up with them from that. But we would look to do that by the end of July, and then use that feedback to start in August on our sort of wider framework across all practices.
Just before the evidence that they are providing, when's it dated? I mean, is it dated pre the Panorama documentary, or has it been dated post?
So we've looked at all data before and afterwards and during that time frame. So the Panorama film was filmed in April. Obviously, it wasn't released until much later. So we've taken a 12-month shot of information. So it's rather than just a snippet of when the program was filmed.
Yeah.
My concern is that if, for example, any evidence is being presented, say, beforehand about, say, supervision of physician associates, and you know from the documentary their guidance or their policy was not being complied with, or that's even more worrying. They have a policy and it's not being complied with, and in fact that's a very limited weight, isn't it, if you know that they're saying something and it's not being done. So I mean, have they actually acknowledged there was a problem, and they've said, look, this was the problem, this is what was going on, and we are revisiting our policies and now doing this? Or are they not even accepting there was an issue?
So I don't think they're sitting there saying there wasn't any issue with maybe a member or two members of staff. There were policies in place. They are using this obviously as a learning experience. However, there were robust processes within that organisation. So again, it's like I said, it's the evidence that again is we've only been able to see on screen. The BBC weren't able to share that evidence with us. So we've had to go in and actually look up the evidence that we would expect as commissioners of what is good and what would assure us. And so far, like I said, the evidence we've seen and been supplied would suggest that they have got robust systems in place. And yes, there were some areas where there are failings or learnings within it that they need to improve. But from what we've seen, we know there's obviously we are assured by that.
The colleagues have. I've got another question on op rows. I've already got questions on op rows. No, fine. But then, okay. So can I just to bring op rows then maybe to a close? So what happens if in 6 months Panorama revisits it and say undercover operation, and there's still no supervision of physician associates? What do you do at that stage? Where does this go? Where do your powers lie? You've got the power to revoke a contract?
So ultimately, there would be a breach notice applied to the contract as part of the NHS England kind of operating model. As you'll be aware, that other practices around CQC have visited and found them wanting, and we have terminated contracts. So yes, we would do that. From point of view of patient safety is our ultimate kind of ensuring that happens. So yes, it's about applying contractual NHS England regulations to do that.
Yeah.
Sorry.
Yeah, and we have done that in instances with other practices. So we do regularly use contract sanctions where required, and work very much in partnership with the CQC.
Yeah, we wouldn't treat them anything differently. Like I said, there will be, so like I said, CQC have also gone in, and I hope that report might have come out sooner. So obviously, because there were areas in there that they've been able to review as well. So it's that.
But you're saying they're not currently at a level where you would consider them at a breach?
So there are no. From the point of view of learnings of the areas of the information that we've got and what we've seen and the evidence that we've seen, they are not. No.
No.
Okay, I mean, this may be something we wish to sort of possibly return to, maybe not just say per se with OPROs, but just generally the framework as to how GP practices and the assurance framework are monitored, just so we have a better understanding going forward as to the different levels and the different stages. So that may be a future item. But if there are no more questions, let's just close off the OPROs then. So I think we've asked a few questions. I saw other hands. I saw Councillor Adams first.
Thank you, Chair. I've got my question is on the Community Diagnostic Hub. I'm just wondering, how does the plan to cite a diagnostic hub at St. Leonard's is compatible with the Martin's overall plan for the site? That's my first question. And the second one is on the monkeypox. Now that the WHO has declared monkeypox as a global emergency, I'm just wondering, apart from the guidance that they put on the website and the social media campaign, I'm just wondering if there's any physical structure in place to deal with this infection at the moment.
Thank you. I'll ask Nicholas to come in on the first and Diane on the second. If that's okay.
And Councillor Adams, as well, but your ward covers St. Leonard's, is that right? Yeah.
Hi. The St. Leonard's reference in our documentation is one of the sites that could be a possibility for future expansion as site 3, 4 or 5 in our network. We are working on a fortnightly basis with the Homerton and other stakeholders in City and Hackney to work with them so that the voice of City and Hackney is heard loud as to where they would definitely like the site to be located. Should we cite a further community diagnostic centre in Hackney? St. Leonard's is given as an illustrative example, such as other places, such as Westfield in Stratford and the St George's Health and Wellbeing Hub. So all of those sites are by no means advanced or confirmed as the chosen sites. So we are working with the Homerton to ensure that if a site is decided to be located or proposed to be located in Hackney and in St Leonard's, that it has the full support of Homerton and the other stakeholders in the City and Hackney system.
Sorry, I should also put Anne Hepworth in as well. Anne, do you want to introduce yourself as well?
Yes, thank you. So I'm Anne Hepworth. I'm Director of Strategy and Partnerships at BHRUT, but I'm also the Senior Responsible Officer for Community Diagnostic Centres in North East London, which for short is the SRO for CDCs in NEL. So I just wanted to add to Nick's point there, which is this is a system-wide plan that we're putting together around community diagnostic centres, and the way in which we are looking at locations is really based on population health need. So we are looking at a range of different factors that we need to take into consideration to make sure that we meet the initial objectives of the community diagnostic hubs, which are about improving access, which are about increasing the number of diagnostics that we can actually deliver. But also just making them more accessible to people in the community. So we'll be using a range of different data points and different insights from local people such as yourselves to be able to help us identify where the CDC should be based in the future.
Diane, do you want to come in on monkeypox?
Yeah, thank you. So we're treating our response to monkeypox in the very same way that we had done with COVID, as a system-wide approach. And we have twice weekly incident meetings where we liaise on our strategy around how we will implement the vaccination for those at risk, those who actually have been identified as needing treatment, but also staff who are supporting and working with those individuals who are at risk as well. So we liaise with NHS England, and we actually have we've set up clinics across 3 of our sites where we have sexual health clinics, and we are vaccinating people that come into contact with monkeypox, but also the staff as well who may not be showing symptoms, but because they are caring for individuals in that way, then they are being offered the vaccine as well. And so we're taking it in the very same way as we have done with the COVID response. It is a North East London response, and we meet twice weekly to review the uptake and also learning from, is there anything else we need to do to ensure that we keep both our population safe and also our staff.
Is the prevalence of cases in a North East London notably worse than other areas of either capital?
It's not at the moment. We're seeing a higher prevalence around Northwest London and Southeast London. So they have much bigger sites within their acute hospitals to treat that, and they're getting the bulk of the vaccine has been delivered to Northwest and Southeast. But we have a fair amount of prevalence, and we now have enough stock to manage that prevalence. There was an issue prior a few weeks ago where the stock was going to those areas of higher prevalence, and we've been campaigning to say we also need a sufficient amount of stock for our areas, and that has now started to happen.
Councillor Akram.
Thank you, Chair. Question on the enhanced access to primary care. Is this going to be a change of GP contracts where they are going to have to provide this service as core, or is this an opt-in service for GPs and therefore we risk having gaps in service where GPs don't want to participate in this?
So this is part of the primary care network services, and all our practices are signed up to primary care networks. So if you're in a primary care network, then you have to offer enhanced access. So there won't be gaps in services for patients. It will be universal.
Councillor Patrick, had a follow-up.
Yeah, my follow-up is will all the practices within the network have to offer the enhanced access, or will they be able to say that one practice within the network will offer the enhanced access? Also, I wonder, how are they going to staff the enhanced access? I mean, it's widely reported that there is a lack of staff in the NHS. There's a shortage of especially GPs and practice nurses. So I wonder where the staff are going to come from, or are we going to see less staff on other days to enable them to cover the enhanced access? And I also wonder what, how this fits in. I know it's with the previous scheme. What is different from the previous enhanced access scheme? What you see the benefits of the new one?
First of all, every patient that's registered with the PCN will be able to access all of the enhanced access appointments. So you might have one practice that's offering the appointments, but they have to offer it to all the patients in that PCN. So as a patient, you might go to your own GP surgery, or you might go to a different surgery locally, or you might go to a sort of a different health location. But all those appointments are available to every patient that's in that network. If I can remember now, I think your final point was around what's different. So I think what patients might see a bit different here is that there is going to be some more routine type care offered outside of normal core hours. So that would be things like immunisations or flu jabs or smears. So for people that would find that difficult to get to their GP for those kind of services, there will be more opportunity to get that kind of routine care at a time more convenient to them in the evenings or the weekends.
Thank you. I don't know if William wanted to add anything, please. And Alison, Alison, can you turn off your mic because you're leaving it on between? Thanks, William.
Yeah, thanks very much. And I think also the what would be different, I think this will be very much more of a local service. So historically, obviously the extended access service potentially was delivered by one of the federations. So again, those larger hubs. And actually the new kind of PCN DES allows much more kind of local, as you say, delivered potentially from a practice in a PCN, so much more local. Obviously, Alison's covered any of the other areas there.
But no one covered my problem about staffing.
So staffing, obviously, yes, there is a shortage of GPs, practice nurses. I think from point of view of by that aggregation of becoming a larger provider. So if you had 5 practices, they would collaborate to be able to deliver that. And again, using different staff groups. So as Alison said, this is not for urgent care. This is for pre-booked appointments for the normal kind of business as usual, as you call it. So immunizations, obviously practice nurses may have a half day in the week and maybe work on a Saturday. So from point of view of, there isn't a magic tree for additional staff, but it's how they get deployed and actually work at scale and pool that resource.
But just from a patient perspective, if I've got it correct in the answer to Councillor Patrick's question, say a PCN is made up of, say, 5 or 6 practices. The new enhanced service requires essentially one of them within that PCN network to open on the Saturday between those hours, and then one of them to be open between that 6:30 to 8:30 slot in the evening. So if I've got that right, then what are you doing on the patient interface front to let them know? Because I mean, this is where a large number of residents interact with the NHS, and suddenly being diverted to a surgery that's not theirs, and then sort of being confused or losing confidence or thinking something's going on. How are you communicating this to patients and residents as a plus, as a benefit, rather than I've been sent somewhere that's not my GP and I'm cross about that, or what's going on?
William?
Yeah, thanks. So very much, obviously, as Alison was saying, as part of this whole change, we have sent a questionnaire out to all patients in North East London, and we've had a 40,000 return rate. They're also working with their PPGs at a practice level from point of view of that access, and I think it's around how the PCNs will advertise and communicate with all of their patients around access. So these are pre-booked appointments. They aren't urgent care appointments, they're pre-booked appointments. So actually it's around the plan that the PCNs will put in, and obviously we have another process that we need to follow, whether that will meet the patient need and also the criteria that NHS England have set out from point of view of that deliverable. But I think from point of view of how the PCN forms it, so one of your things was it could be one practice. There could be more than one practice. There's a formula within it that states how many kind of sessions or how many hours they need to be open. They need to open. So actually, it's not necessarily just one practice. There could be 2 or 3 practices that are open, to be able to deliver this service. So again, as we haven't seen the plans, they come in at the end of July. So I really, can't sit here and say, yep, we've got all of the plans in, and we are able to comply and say, yeah, all of the practices will be open. It's unlikely, but ultimately it won't be just, I don't think, one practice looking after 60,000 or 50,000 residents.
Yeah, I mean, I still think there might be something in a communication piece of work, both to sell it as a positive on a point for residents to know this is a benefit, this is an enhanced service that you're getting that you didn't otherwise get. This is what we're doing, and use it as an opportunity to explain. It can be done in a couple of sentences that sort of how PCNs work. It's part of a collaborative. It's not a question of taking you away from your GP surgery. It's trying to increase it on top. And I may query whether giving wording, giving guidance for websites, giving all of that to the different PCNs to assist them, because I can just see if you just let them all do it in their own way, most of them aren't going to explain it, and you're going to get somebody who's used to going to X surgery suddenly sent to X, confused. Whereas you could sell it as a positive, and that increased confidence in the local NHS for what you're doing, but B, also explain how PCNs are working and use it as a tool. So I still don't. It strikes me there's more work that could be done there.
Yeah. So sorry, Marie. So again, comms is very much important, and obviously we're engaging with Health Watch as well around getting that message out locally. But again, there will be a whole comms background from point of view of, because it's around how you access your general practice now and that opportunity to go and see somebody on a Saturday. So the access route would be through your own general practice, and it's around how we encourage and make sure that those practices are engaging in this, to like saying, give that positive message to say, did you know you can come and see us on Saturday, rather than having to, early mornings or whatever. So, and the urgent care provision obviously is separate. So again, is what we don't want to do is confuse the residents of which way do they need to turn when. So that's why it has been separated out.
Any further members' questions? Nicholas, can I just ask you on the diagnostic hubs? I was trying to understand. Is it the case that essentially this was pots of money that were being offered by national government that we thought, yes, we'll apply for and do that, and yes, we can have more diagnostic hubs closer to different community groups, as opposed to sort of a North East London plan in and of itself? So I suppose coming into it, one of my initial course questions was, what is the evidence base that you increase numbers, throughput, by, say, putting them in these different locations vis-a-vis, say, one central location? Is there an evidence base behind it, or is it actually not so much being driven by that, but is it just being driven by the fact that national government or national NHS were offering money for this, and of course we applied for it because we could do with more resources?
Is it Nick or Anne who's first? Anne, go ahead.
Yeah, thank you. So overall, the evidence base that we've got, we can base very much on the COVID vaccination plan. So one of the things that we were using there was the WHO guidelines around inequalities and reducing inequalities. And some of the key things, and a huge evidence base around reducing inequalities, is about increasing and broadening access to various different services. So we're using that as part of the basis. From our perspective in North East London, the kind of data that we were using is looking at demand against current capacity, starting to estimate unmet demand in terms of diagnostic services by looking at some of the population health analytics against some of our more deprived communities, for example, and also using a tool called the SHAPE tool, which started to look at driving times and times via public transport to various different locations that we already have diagnostic facilities in, but also starting to help us plan with new diagnostic facilities should be as well, just to broaden as much access as possible. But it's an excellent question, Councillor Hayhurst, and one of the things that we are desperately trying to do is to make sure that our decisions are based on evidence, and particularly population health evidence that looks at broader data than simply health activity and starts to look at some of those wider determinants of health.
And presumably you're going to be monitoring it in terms of throughput or numbers, possibly pro rata to resource. And then if you see what a significant trend, then that furthers the argument for possibly a furthering of, say, of that programme.
Exactly that, yes, yeah, and not only in terms of throughput, but also in terms of patient experience as well.
Thank you. Can I bring in now Ralph Coolbeck, and congratulations on your appointment at WIPS. Ralph, thank you for coming along today. Particularly, there are a few stories in the Health Service Journal in May and July in terms of funding for the 14 new hospitals, or as badged, and concerns that the amount of money being allocated to the WIPS project is comparatively a small amount, say £1 million for planning in the next financial year. Has there been a slowdown in the funding? What's the update on where we are? Is a concern?
So we've just put a couple of slides in the pack to try and explain the position to the committee. In terms of our state of readiness locally, there's really good progress on the redevelopment programme. We've got our planning approval. We've completed the first phase of enabling works. We have a business case both for the second phase of enabling works and the wider redevelopment that's well advanced. And we've made good progress with beginning the clinical transformation required to support the redevelopment. We are still awaiting further clarity from the national programme about the timelines for submission of our outline business case, and that remains the key next step in the process that we really want to understand and move forward on. We have had some indications that there's likely to be decision making in the autumn that could pave the way for us to submit that case, but we don't have a guarantee of that at this stage. The £1 million that was allocated to us as our initial programme resource allocation for the year, which I think was reported in the HSJ, that was an initial allocation. It wasn't necessarily designed to cover everything we need to do this year, and it certainly wouldn't cover the costs of the substantive next phase of work, but I think it was allocated in recognition of some uncertainty about the activities this year. And it was the same allocation to all schemes, so it wasn't really a reflection of priority one way or the other. It doesn't give us an immediate problem with the WIP scheme because we have done some of the more resource intensive activities such as planning development and the planning process already. But certainly if we were to proceed to the next substantive phase of work, which we obviously hope to, we would need a bigger amount of programme funding. We have had assurance sort of informally from the new hospitals programme that any decision for us to proceed to the next phase would be accompanied by an additional allocation of funding to support that work.
I think there are certain pathways, how I've forgotten the terminology, pathfinders. I mean, where does the WIPS project fall? Is it sort of in a priority 1 band or not, or is it in a lower priority band, or are they not banded in that way?
Well, the way that the programme is divided, it is complicated. I apologise, and it does change regularly. Effectively, the new hospitals programme has been divided into a number of cohorts. WIPS cross redevelopment is in cohort 3 of the programme. Cohort 1 refers mainly to schemes that were already in construction. So therefore, by definition, we couldn't be in that cohort. Cohort 2 refers to a number of smaller schemes that are much less expensive and smaller in scale. So again, we couldn't have been in that cohort either. Cohort 3 is the 8 schemes that were previously referred to as pathfinders. And these are seen as the most advanced whole hospital redevelopments within the national programme, of which WIPS has always been one, and there are 7 others. And then cohort 4 refers to the remainder of the 40 schemes that were identified and are generally at a less mature stage of development. So we're focused on obviously cohort 3 moving forward as quickly as possible. There have at different points been indications that cohort 3 could be subdivided into groups of differing priority. That has never happened formally, but it may still occur if there's a challenge with proceeding all 8 cohort 3 schemes at once. We've had a number of assessments of the scheme and various pieces of formal and informal feedback from the new hospitals programme. And we believe on a technical level and just in terms of our overall state of readiness, we are certainly at the much at the advanced end of cohort 3, if that makes sense. And probably the best indication of that is we think there are 3 schemes in cohort 3 with a planning consent of the kind that we have, and so obviously WIPS is one of those 3 schemes.
I suppose being slightly cynical, if from a PR perspective, if a government wants to say it's producing results, it goes through the scheme 2 lot quickly, because then the smaller builds easier to deliver on than the harder 8. So
yes, we expect cohort 2 to proceed much more quickly than cohort 3. That's correct.
Thank you for that update and giving us some understanding. So I mean, when if you do get an update, I think we'd appreciate. I know there's a particular sort of scrutiny commission looking at this based around water and forest, but I think we have an overarching view because of how much this feeds into the bigger picture. If you could just, when you know more and you're in a position to say more, if maybe you don't need to come along, but we can just get an update as to where we are. That would be appreciated. Thank you for coming along today, and I think that's it for questions for you. So please feel free to sign off now. Can I just before we wrap up this, can I just ask, I'm looking for any further members' questions. I've got one more for Diane, if I can, on the consultation that's due to close in September with respect to the continuing healthcare policy. I mean, it's difficult at the moment just to get, a grip, for us to get a grip and an understanding as to how far-reaching this will be and how much it will bring in local authorities changing their impact upon local authorities, whether it's essentially, to be crude about it, a levelling down, a levelling up, widening access or not. I'm sure you might not accept those parameters of terminology, but I mean, you know, looking at it from a sort of a scrutiny way. You mentioned that this process with a small group of local authority leads. Are all local authority heads of adult social care around the table on an equal footing with the redesign of this policy?
Yes, so initially when we started the process of looking at what policies we need to align, if I just rewind slightly, where we had, as I said, there were at place, we had a varying amount of policies and practices in relation to continuing healthcare. And what each place wanted was, what is a systematic way of addressing these issues? And so in some cases, we didn't even have a policy in place. And in others, there was a policy, but it wasn't working well. It wasn't suiting the needs of our residents or individuals. And so there was a call from all corners, whether it was a clinical practitioner, from local authorities, from CCG, to say, can we do something together to have a consistent approach that meets the needs of our residents? And so in some cases, there are existing policies, and where we've reviewed them with our local authority colleagues and with clinicians, it's seen as best practice. The proposal is that we should adopt them across all of our boroughs. In other cases, there are no policies at all, and so we've started from scratch and we've looked at what is national guidance and best policies. And so it will vary in relation to the impact at each place. But what we've got is behind this is we've looked at where, for each of those policies that we're proposing, we've looked at what is the current policy, if there is one, and how does that impact on the proposed new policy. We've done an impact assessment, and we've looked at, does it have a negative impact on our residents, and what is the quality impacts? And we've seen that it doesn't have a negative impact, it actually improves for residents. And what we're working through now is, how does each local authority see those proposed policies? And that's all part of our engagement process. So they've been involved in the start, where these were the policies that we all agreed we needed to look at. And so the prioritisation of which policies was done jointly with our local authority colleagues. And then the workup of what these policies should look like has been shared with our local authority colleagues. So the people that have been working on these proposals are colleagues that work at place, and they've worked with their teams at place and with clinical people to say, this is what we think it should look like based on what is good practice. And now we will start that period of engagement whereby local authority and the public and anyone else that has what's with stakeholder vested interest, it's open to comments and suggestions so that we can write up what will be an agreed policy going forward.
I mean, I haven't actually looked at the public consultation myself. I mean, is it transparent within the consultation document, say amongst the different place areas, what is the existing policy, if there is one, vis-a-vis what is being proposed? And so is it a transparent consultation to that extent? You can see sort of before, after, compare and contrast, or does it not go into that degree of specificity?
The proposed policies don't go into that level of specificity, but behind it shows this is what the previous policy looks like, and this is what the proposed one. So what we've tried to do to make it as simple as we can, because we've had lots of iterations where people said this is really complex and can you make it as simple as possible. What we've tried to do is use a graph or a table that shows real high level summary of, this is what was in the key elements that would change in the current one to what the proposed is. Or it will say a policy doesn't exist, therefore this would be a new policy to be adopted at place. And so what we do have is behind that is a very high level summary. But what we have endeavoured to do is to say if anybody wants to have those levels of detail, then we are open to having formal informal discussions with people to actually go through the details, because it's quite hard to gauge sometimes the level of details that people may want. And so we've not gone into that level of detail, but we have said that we are more than happy to have those detailed conversations at place with local authority, with carers, with their representatives as need be during this period of engagement.
Thanks. I mean, I'm looking colleagues at slide 48 in our pack. For example, one of them is joint funding policy for adults, as to how NEL will jointly fund with local authorities. So it may be that that's a job for each of us respectively to go back to our respective heads of adult social care and understand how that's impacting us locally, whether it be budgets, processes, staff resource, and what have you. I mean, and just so we can get more of a grip of that. And it may well be, I mean, I flagged this, Diane, it may assist, maybe as a deep dive, maybe a future meeting, maybe just to take one, and it strikes me the top two stand to be corrected, the perhaps more overarching, have more overarching consequences, and just to sort of understand in a more deep dive as to what the different policies were and what's being proposed, just as partly as training and us education, but also so we can scrutinise it. So that may be one for a future meeting. So if the consultation closes mid-September, when are you then hoping to come out with final plans?
So depending on what we get and what gets fed back to us, we do want to do a sense check again with our cohort, our specialist group that pulls this together. But we'd be hoping that we'll have a final policy 4 weeks from the point that the consultation closes, and then we would phase in an implementation plan around when these new policies would actually come into place. So once we've got the final policy and we share that for comments with our local authority colleagues and others, it would then go through a governance process before it could be signed off, and then there'll be an implementation plan to when that would then come into effect across each of our places. So I don't think we'd actually see the actual changes this side. It probably from January onwards, because we feel that it would likely be that we've got to make sure that everyone feels comfortable with that new policy before we can actually implement it. So there'll be a period of training maybe in relation to that. So it's not going to be immediate. Once we do have a final policy, we'd have to phase it in and make sure that the implementation works for each of our places.
Thank you for that. Well, it may be for one of the meetings later on in the year, then maybe when the consultation's closed, maybe just to take one of those as a deep dive. Maybe we can come back with a suggestion there. But in the meantime, I think it would be assist if we all go back to our heads of adult social care to understand the impact from their perspective. I'm running slightly over. I know that my colleague who was going to do the Whips Cross presentation can't join us, so we've got a little bit more time. So I'm just going to ask, if I may, unless there's any other questions from members. I've just got one other question in relation to agency staff, and then I'll close this item. I think it was reported again in the Health Service Journal about caps on ICSs, about agency staff being at 10%. I mean, is this anything that has been fed down, or is this just something that's been a balloon story that's just been mooted in the health media?
Henry will be able to answer that.
Yeah, so this is something which is now part of national policy. Every ICS, excuse me, every ICS has had a.
We're losing you, Henry. Henry, do you want to go?
Let me try and turn my camera off. I am having problems with my connection, but essentially the answer is yes. It's part of the settlement, the additional money that was given to the NHS to support the inflation pressures. One of the conditions on that was that each ICS has a cap on agency spend. So every ICS in the country has this.
What does that mean in practice? You have to look at all your secondary care providers, all your primary care providers.
Yeah, basically, it looked well. Yeah, essentially, yes. Across the whole ICS, we have to reduce our reliance on agency by 10%. So that means switching where we can from temporary to permanent staff and from agency to bank. But it's a tall order, but it's one that we're going to have to tackle like everyone.
I mean, the concern is it's just unrealistic in the current climate when there's such a staff retention and attention policy in the first place.
Yeah, it's difficult. I mean, playing devil's advocate, I would say that we spend too much money on agency now, and we do have an opportunity to do that. So I think it's going to be really hard. But to some extent, generally speaking, the feedback we've always had when this has happened is it's really, really hard. But it does actually, in some ways, it helps because the labour market responds and people know that it's going to be harder for them to get agency shifts, so they tend to register at banks, and it makes it easier to. By banks, I mean the short-term shifts that are done through the NHS. I'm not talking about high street banks. I'm talking about.
and presumably the distinction there is that bank staff cost the NHS less.
They do on the whole, yeah, they do, yeah.
Well, thank you all very much. We covered a lot of different areas there, so thank you very much for that. That was very informative. And thank you all for your work. I think Zina had possibly alluded to possibly a future meeting in terms of some work that's going on with the acute specialisms. So that may be something for a future meeting. It may also be a deep dive that I alluded to into some of the work that's been going on there with the local authorities. Thank you all. So with that then, I will bring that item to a close. Can I now then turn to what is item number 7, which is proposed changes to fertility. We've got Diane Jones, who's been with us before on the last item, and also Dr. Gupta, who's the clinical lead across North East London for this. So this is a harmonisation of fertility policy across North East London. Though colleagues in Hackney, we've had a special briefing on it already, and I'm happy to summarise. It was very much a feeling that it was very much a levelling up rather than a levelling down from the feedback we were getting, and also from sort of people who are in the area as well. So can we have Diane? I don't know whether you're going to kick off with this for a few minutes before I open it to questions.
Yeah, sure. And then I'll bring in Dr. Andrew Gupta. So just to say for colleagues that may not have been at the briefing, as you said, it is a harmonisation of policies, and we're not looking to cut funding from this service. But what we've looked at is what is best practice, what would work, looking at the NICE guidance, and actually in some cases we've gone above what is NICE guidance. But really we're proposing really a single updated unified policy for those who live in our boroughs of North East London. And we've used, like we said, the National Guidance Clinical Excellence, and we've also had a clinical specialist experts to review the policies and what would good and best look like for us. And so we're covering 7 areas on the proposed policy, from eligibility criteria through to ovarian reserve criteria. So it is quite technical, it's quite clinical, and that's why we've got Dr. Andrew Gupta that will be able to answer those clinical questions. But absolutely what we want to do is to enable people who want to get pregnant and family partners who want to conceive, to enable them to do that. But because there will be some financial constraints, because we have to ensure that we can deliver services in a range of areas across North East London, we are looking at those who have a medical reasons for requiring assisted conception and fertility support in the main instance of this. Dr. Gupta, do you want to add anything in terms of how we've gone about this? You're on mute.
I got you on mute there. Still on mute, Dr. Gupta.
Oh, don't worry. If hopefully you can come back in, but if not, if I just continue and just summarise by saying that, are you back? Sorry. Oh, no. So just to continue, in terms of the areas of priority, like I said, it's people who have a medical condition. We have looked at a number of areas, and some of the differences that you may see is it's the number of cycles and the age that we will go up to in terms of in our proposed policy. So it increases access for majority of people within our boroughs, and we've also done an equality and health impact assessment as well. So we've identified that it will benefit rather than be a negative impact on our residents as well. We've opened up the consultation. We have done a number of engagement events so far. We've sent out a survey. We've sent it to about 230 stakeholders. We've held 2 public events so far, and then we plan to hold another 2. But we've also given people the opportunities to email in questions. We've developed a frequently asked questions sheet as well that we'll be updating and sharing at the end of the engagement process. And we've also ran some other sessions with stakeholder groups as well. So we've tried to engage in a variety of ways to get a maximum coverage of this so that we can get as much views as possible going forward. Thank you.
Just while Dr. Gupta is seeking to log back in, Henry, what's the if this is widening of access and essentially levelling up of number of cycles to full cycles to 3, how much extra budget spend are you anticipating allocating to this?
So we are still working through that, but it's going to be in the low millions, we think. So it won't be huge on a £4 billion budget, but as part of as you say, levelling up and eradicating any kind of postcode lottery, it's a relatively small amount of money.
So are you able to, has that worked, logging off and back on again? I fear not. Sorry. Councillor Patrick, I know you had a question.
Yeah, I just wonder how people can prove or know medically that they have a problem. I can understand using inappropriate language that men and women who have sex with each other after a certain time, if the female doesn't get pregnant, they can think there's a problem or guess there's a problem, they go to their GP. But how do people who can't get pregnant without assistance for whatever reason know that there's a medical problem to go and find out whether they do have a medical problem and whether they need medical assistance to fit into this programme?
Thank you. That's a good question. So in the main, people would have, like you say, have tried to conceive in one way or another, or they would have had treatment when they were younger to know that they have a fertility issue. So there are majority of people may find that through a sexual encounter, but there are others that we will come across who will know that that is an issue because of previous surgery. For example, someone receiving cancer treatment who has to save their cells, we know that for them they would come under this policy as well. So there's a variety of ways that people will be eligible for treatment under this this policy. There's also those who maybe have been in a previous relationship and has now entered into a new relationship where one or other of the partner are unable to conceive or contribute to that conception. So it's a variety of ways, and those are what will be discussed with their GP in the first instance around what are the issues or the challenges, and there will be a number of tests and diagnostics that will be done to try and determine what the root cause of that challenge or that issue may be.
But it's not the case that the cost, say, of trying to prove that is passported onto the patient or the resident in any particular way. So there's no sort of cost barrier or inequality barrier there. Essentially, if a couple are having problems conceiving anyway, they would come, they would seek help, they'd be put on a pathway, and there's sort of no cost barrier towards that evidence base of their medical need.
Yeah, that's correct. So it's part of the core offer for NHS care, whereby if a couple or an individual goes to their general practitioner, that they would be put on a pathway for tests to be done in the first instance, and that's part of the NHS offer.
Thank you. Now, Dr. Gupta, I'm not sure if you tried calling in. Has that worked? She's trying. She's trying calling in. Just while she is, I mean, one thing I learned at the briefing when it was for Hackney that I hadn't fully appreciated before is that there are weight and smoking policies in play. So if you smoke, that will be a factor. I don't know how it's done in terms of whether it's done on a point score, a crude point score, that may factor against you in terms of whether you're offered fertility, and also either on terms of BMI, either too high or too low. I suppose the questions there in terms of access is what support you give to those people who might initially fall within those brackets, and support you give to get them to a place whereby they do qualify.
Sure. So we know that smoking and weight can affect people's chances of success within conception, whether it is by natural ways or through the assisted conception. So what we'd want to do is to advise resident patients of, you know, some healthy options in terms of smoking cessation, and offering them programs of support that they could go through, and also around weight management advice as well, because if they're at an optimum level of health, they're more likely to have success within their assisted approach to conception. So we would have to give obviously dietary advice and smoking advice, and there might be other health components as well that needed to be discussed in relation to their individual circumstances as well. So that would be part and parcel of that process of before the offer of some sort of assisted conception is made. That is part of the pathway in identifying how do we get people to their maximum health need to enable that assisted program to be most successful for them.
Yeah, and just quick query, is this, the BMI has obviously got some flaws with it. Presumably it's not such a crude measure as that. It's not on some sort of point scale, because, clearly there can be other factors there as well. So presumably it's not a crude BMI score, that if you're over this, that's it, or, Yeah,
it would be a combination. So the GP will make a full assessment of their health needs, and they would refer them for whichever those services will enable them to have the best possible chances of a successful assisted conception. So, for example, with BMI, it would be around weight management, but it wouldn't just be BMI on its own. It's be looking at a whole holistic approach to their health and their well-being.
Dr. Gupta, any joy on the? I'm just trying to see if we've got any call in. Still trying. Thank you. Any other members for questions? Well, can I thank you, Diane? I think it was some feedback I think we gave a few months ago in terms of the consultation about it being completely clear and transparent about what was being proposed. I think we felt that was taken on board, so we thank you for that. I'm in danger of finishing early, so unless I think we've possibly got Dr. Gupta on the phone, which may assist. Dr. Gupta, are you with us on the phone?
Yeah.
Sorry, just good time. Doctor, let's just try this, and then I think I'll have to call it a day. You're being suggested. Please press 6 on your phone. You press 6. I think, and then that might enable you just *6. No, does that help? Is that? Aha! We've done it. Thank you, Mario. And now, can you silence your computer, which is giving some feedback?
So Diane has really addressed all the concerns and questions. It is basically a leveling up, which I think should be a very positive news for couples looking to conceive. The proposed policy.
So we're getting quite a bit of feedback there.
I have muted myself on the computer. I can feed back later, but I do apologize for the sound sheet today. So sorry.
you're on mute, Chair.
I can't hear Ben.
You're on mute,
Is it
Chair.
just me?
You're on mute, Chair.
Thank you, Chris. Thanks, Dr. Gupta, Diane, for your work on this. We've been happy that our feedback's been taken on board, and it's essentially across the different boroughs. It's essentially been a levelling up of provision. So thank you for that. So with that, then I will draw that item to a close. Members, item number 8, we were due to be joined by Councillor Sweden. He sent his apologies. He pre-booked a holiday before he knew of today's meeting. He's the chair of the Whips Cross JOSC meeting that's looking at the Whips Cross development. We've had an update from that in any event today. And I understand Councillor Deakin is also on that. I think we've had the update from the new Chief Executive Whips on where we are, so I don't think we can take that much further. So I won't spend any more time on that. Item number 9, I know some of you weren't here, but please can we agree the minutes from the previous meeting? Thank you. Now, just before we close the meeting, item number 10, we've got the work programme. Clearly, the NHS want to bring some things to us in terms of what was alluded in terms of Zina talking about acute specialisations. We've discussed some other things. If you've got any other particular ideas of things that you want to cover in the next year, please email myself and Jarlath with those different suggestions. It may be we've had a regular running update every meeting on the ICS progression. It may be slightly rowed back from that now, because it will become slightly duplicative because we know where we are. But I still think we'll obviously still have the updates from recent changes on the NHS. But if there's any other particular areas across the new ICS, please let us know. So with that then, I haven't been notified of any other business. Thank you everyone for joining. And with that, and can I give a very special thanks to our technical support, Mario, who's joined from holiday to be here to provide the support. So thank you, Mario, that's much appreciated. So with that, I'll bring the meeting to a close. Thank you.